Welcome all. Welcome to PROSTHONEXUS 2025. I'm Dr. Shilpa Dandekari, Professor in Department of Prosthodontics, A.B. Shetty Memorial Institute of Dental Sciences, NITE, deemed to be university. First of all, I would like to thank Karnataka Prosthodontic Society, the organizing committee, and the host HKES'S NIJALINGAPPA Institute of Dental Science and Research, Kalaburagi, for coming up with such a beautiful program for postgraduate students. So, before I begin, I would like to quote, "Knowledge is power, knowledge shared is power multiplied." I think this goes very well with our theme today, that is connecting knowledge and crafting excellence. So, the knowledge should be connected and multiplied. The topic of my presentation is role of tongue in prosthodontics. Coming to the next slide. Here I've just attempted to make a flow chart which will help the postgraduate students to fabricate a similar kind of a flow chart for that particular topic, so that it helps them to score better in their university examination. Okay, the flow chart should have a gist of all, or the key points of the topics, and then it is always better to include a reference point or a reference of an article or a journal name or an author name, which will fetch you better marks. Moving on to introduction, the tongue is a muscular organ situated in the floor of the mouth. It has an oral part that lies in the mouth and a pharyngeal part that lies in the pharynx. Tongue has been the disturbing factor in every stage of dental prosthesis. Since it cannot be eliminated, it must be accommodated. This particular statement, that the tongue cannot be eliminated, so it must be accommodated, makes me I love this statement. Why? Because this particular organ, that is the tongue, which is movable, it is such a small tiny organ which is movable inside the oral cavity, but imagine the amount of trauma, amount of tension it gives to us when from the case history recording till our final dental prosthesis fitting. Okay, so we have to learn the function, the anatomy, the physiology of this particular organ, such that we can modify, we can do a better technical skill, such that the finally patient care and quality of patient is life is improved. Next, coming on to embryology. This particular slide of embryology is very important because we have to know the origin of the development of tongue. The origin is important because there are many pharyngeal arches involved in the development of tongue. It starts in the 4th week of intrauterine life, and then there is this 1st to 4th pharyngeal arches which are involved in the development of tongue. So as you can see in the first pharyngeal, there is mesodermal thickening. These are the mesodermal thickenings which are seen on the foregut, which tries to join the contralateral side of the contralateral side, and during this fusion process there is from the first pharyngeal arch two lingual swellings which are formed. Along with the lingual swelling, there is also one more third swelling which is formed, which is fused to the two lingual swelling, which is known as tuberculum impar. This tuberculum impar in later stages disappears and it remains as your foramen cecum. This foramen cecum is also very important because it is the final thyroid duct, thyroid duct, and the thyroid gland is originated from this foramen cecum. So here the first pharyngeal arch is playing a role. Now coming to the second, third and fourth, the second one is always submerged and the third overpowers that. It overgrows and then forms, and there is one more swelling, two swellings which are formed at the from the second to the fourth pharyngeal arches, which is known as hypobranchial eminence. Okay, this two swellings are very important for us to know because here the tongue, that is the anterior two-third, is formed by this lingual swellings and first pharyngeal arch, but your posterior one-third is formed from 2 to 4, that is your hypobranchial eminence. Especially the fourth pharyngeal arch plays an important role here. Knowing this discrimination is important because the nerve supply varies because it is from different pharyngeal arches, and also the parts which are formed is a little because the the derivative is first and the fourth, and when second to fourth it is a little different. Okay. So anatomy of tongue, basically the tongue is divided into apex, the body and the root. The root is fixed, as you can see, the root is fixed into the palatine process, and also it is fixed at the pharyngeal part. Okay, but the super movable part is the apex, and then we have the body. Now this particular cross section, this particular region over here is your dorsum of the tongue. Okay, now moving on to the dorsum of the tongue. Again, an important structure which we have to remember over here is the sulcular terminalis, that is present over here. The center of that is the foramen cecum. The two limbs are fused by foramen cecum. So this sulcus terminalis, which is located here, is very important because it divides the anterior 2/3 and posterior 1/3. Now anterior 2/3 basically constitutes of all the papillae, and the posterior 1/3 constitutes of lymph nodes and your lingual tonsils. Okay, so that is what is present in the posterior 1/3. Now moving on to the next slide, that is, we spoke about the dorsum surface. Okay, now we have to speak about the ventral surface, that is the inner surface. When you roll the tongue up, what is visible? You see a bluish hue, that is nothing but deep lingual vein. Okay, just medial to it is a fimbricated fold, and lateral to it is the lateral to it is the fimbricated fold, and just medial to it is frenulum linguale. Okay, this is the frenulum linguale, which is medial to the deep veins, and lateral to it is your fimbricated fold. This is a short video to show exactly what I spoke till now, because whenever we see a video and we understand the organ, it is well registered in our brain. So this is an attempt to again show you the same thing, that is anatomy. This is the base of the tongue, okay, which is attached near the pharynx area, and then we have the tip, which is movable. Then we have the body and the base, and the dorsal surface, the body, and the ventral surface of the tongue. So these are the two lateral margin which fuses, and then there is the root surface which is present. So we were talking about the anterior 2/3 here. The anterior 2/3 is consists basically of different papillae. There are four kinds of papillae which are present, that is circumvallate papillae, filiform, fungiform, and folate. The name is derived because of the shape they have. Now circumvallate papillae is more in a circular form. The filiforms are projections, finger-like projections which are present. The fungiform is more of mushroom shaped at the cross section, and your folate is more like a follicles. So these names have come. So valate is just next to the, had spoken initially about the sulcular terminalis. So this is the sulcular. Just ahead of the sulcular terminalis is your circumvallate papillae, which are large in size, and they are 8 to 12 in number. And then they have the taste buds present in them. We have filiform. The most important point here to remember about the filiform taste bud is that they have no taste buds in them. Okay, so they are again finger like projections which are present. Where they are present, they are present at the presulcular area. As you can see here, at the presulcular area over here, the filiform papilla. Fungiform papillae are also present at the lateral surface of the tongue, which are mushroom shaped, and they are numerous at the margins and the lateral surface of the tongue. Folate papillae are again present at the lateral and the dorsum surface of the tongue, and they are follicles are present and they are many in number. Okay, your other rest of the all three other than the circumvallate papillae are numerous in number. Again, this is a short video to show, okay, that how your this is how your circumvallate papilla at cross section. It is circular in shape and it is very big in size compared to the rest of the papilla, and then this is how it appears. Okay, so then there is this velum which is present, which is valley like. This is how, this is the sulcus terminalis and these are the circumvallate papillae. Now fungiform papillae are mushroom shaped papilla which is present at the side. You can appreciate them over here. Okay, they are present over here at the lateral, and this is how you can see they are mushroom shaped papillae. Folate papillae are again present, are the at the cross section they are more like vertical, or they are more follicle shaped papilla, and they are again present at the lateral surface of the tongue. You can see here they are more the follicles like hair follicles, these papillas are present. And the last one is the filiform. They are finger like projections which are seen, and they are numerous in number. And most important thing what you have to remember about filiform papilla is that they don't have any taste buds. They don't have any taste buds in them, and they are numerous in number, and they are also located at the dorsum surface of the tongue and at the lateral surface of the tongue. The filiform papillae are present. The at the cross section they are more hair like structures, or they have projections which are present. Now coming to the next most important topic, that is muscles of tongue. Muscles of tongue are divided as intrinsic muscles and extrinsic muscles. Intrinsic muscles constitute the major mass of the tongue. Okay, and then your extrinsic muscles are basically they have an origin and insertion. Okay, the origin and insertion are a little far away, and then we have your intrinsic, under intrinsic muscles we have superior longitudinal, inferior longitudinal. So it is easy to remember it, the name contradicts each other. Okay, there is a superior longitudinal and there is a inferior longitudinal intrinsic muscle which is there. Okay, and then there is this vertical and transverse muscle which is present. Okay, under extrinsic again there are four types: genoglossus, hyoglossus, styloglossus and palatoglossus muscle. Okay, these are the different muscles which are present. Okay, so we have this, as I told you, eccentric and intrinsic muscles. Let us move forward. So what are the actions and where these muscles are present is basically I'll be talking in this particular slide. So superior constrict just lies beneath the dorsum of the tongue, and action is it curls the tip upward and rolls it posteriorly. Okay, so that is the action. The antagonist action of superior longitudinal muscle is made by your inferior longitudinal muscle. You can just remember the names also are contradictory, and also your actions are opposite to each other. Okay, so they lie at the lateral to the genioglossus, that is the inferior region of the tongue next to the mucosa, and then there is their action, which is they curl the tip of the tongue inferiorly. This was upward and this is towards the lower direction. Okay, the transverse, again they lie inferior to the superior longitudinal muscle and run from the septum to the margin. Okay, they are basically horizontal in direction, so they are known as transverse. Okay, again this is in reverse to the vertical, which are more vertical in direction. Again their actions also are opposite to each other. Okay, the one that is the transverse muscle, they basically what they do is they narrow the tongue and increases the height, and your vertical muscle basically flattens the dorsum of the tongue. Okay, now your the muscles, that is your extrinsic muscles, we have to know, actually then explaining over here, I think you can see this video. Now in this video you can see the extrinsic muscles which are there. So we have our extrinsic muscles, that is the genioglossus muscle, and then we have our hyoglossus muscle, then there is the styloglossus muscle and the palatoglossus muscle. So starting with the genioglossus muscle, that originates from the genial tubercles, it is, you can see, fan shaped muscle which is inserted into the hyoid bone. So the origin is from the superior genial tubercle to and the symphysis menti, and then they insert into the cornua of the hyoid bone. Okay, there is this three types of fibers which are present. The lower fibers are inserted into the hyoid bone, the intermediate fibers are inserted onto the surface of the dorsum of the tongue, and then there is the upper fibers which are again inserted onto the lateral surface of the tongue. Okay, the main function of your um, genioglossus muscle is it protrudes the tongue and narrows down. There is a concavity which is formed. Okay, when it narrows down, this is the main function. One more thing which you have to remember about genioglossus is it holds the tongue forward. It doesn't allow the tongue to fall back onto the oropharynx area. Okay, it is very important. If it falls back, it is very detrimental. So it is known as a safe muscle. Okay, so the tonicity and the activity of this muscle is very important because it is known as a safe muscle. Okay, and then it rests at the tip of the tongue. Then we have the hyoglossus muscle. Okay, the hyoglossus origin is again from the hyoid bone, upper surface of the cornua of the hyoid bone, and the body of the hyoid bone, the insertion is towards your surface of the tongue. Okay, again this is a very important muscle. At the side of the tongue there is insertion, and also a little bit of the muscle is attached to the styloglossus muscle also. Okay, so the main action of this hyoglossus muscle is it basically it raises the dorsum surface and forms a concave. Okay, and it retracts the tongue. See, because it is at the most posterior area, you have to remember, whichever, because of the origin, it retracts the tongue and keeps the tongue backward. Then we have the styloglossus. The origin is from the styloid process and insertion is again at the lateral surface of the tongue. Okay, at the side of the tongue or the lateral surface of the tongue. So here the basic action of this is it slightly protrudes the tongue and also uh, holds the tongue more backward. Okay, this is how, like a sling, it holds the tongue more backward. That is your styloglossus. Then finally we have our palatoglossus, which is origin is from the palatine aponeurosis, and then at the almost near the base of the tongue. Again this also basically retracts the tongue. Okay, it keeps the tongue back and also it holds the tongue in position. Okay, this is attached to the palatal aponeurosis, like origin is from the palatal aponeurosis. So the action of the palatoglossus, you can see here, see how it elevates the tongue and it is narrowing the tongue and also it is held back. Okay, again this is about your extrinsic muscles. Now coming to the intrinsic muscles, you have your superior longitudinal muscle which is present just beneath the mucosa of the dorsum of the tongue, as you can see over here. The superior constrictor muscle, how they look. They basically, the action is they reduce the length. Okay, they reduce the length and fold the tongue inwards. The shape and the size of the tongue is basically done by the intrinsic muscles, the change in shape and the size of the tongue. Okay, then we have inferior longitudinal, it is lying at the base beneath posterior, this area over here. The action is reverse of that, that is narrowing the tongue. This basically flattens the tongue. Okay, this basically flattens the tongue, that is the action of your inferior alveolar. Okay. So as you can see, it narrows, shortens the tongue, and also it's a reverse function action of your superior constriction. Now we have transverse. You can see the muscle fibers over here. They are more horizontal in direction. The transverse fibers which are present. So what is the action? It basically reduces the width of the tongue. Okay, this width of the tongue is reduced, and vertical is reverse of transverse. Their directions are more vertical. Okay, it was horizontal, but this is more in vertical direction, and the action is it flattens the tongue. Okay, it is reverse of your uh, transverse muscle. Okay, it width of the tongue is increased, that is it is flattening, so the width is increased, and also concaves from side to side. Okay, this is with the intrinsic muscle. Now coming to the arterial supply, the main supply is from the lingual artery, which is in turn a branch of external carotid. The root of the tongue is also supplied by tonsillar and ascending pharyngeal artery. Okay, you can see the carotid and the lingual artery which supplies the tongue. The venous drainage is mainly by the deep lingual vein, which is the largest vein, which is present on the ventral surface, and in turn it drains into the facial vein or the internal jugular vein. The lymphatic drainage is basically at the anterior part of the tongue, that is anterior two-third is drained to the submental and submandibular, but the posterior most area is drained to the jugulo-homohyoid lymph nodes. Okay, as you can see here, the jugulo-homohyoid lymph nodes, there is the lymphatic drainage of the posterior area of the tongue. Now we have the nerve supply. As I had mentioned, the nerve supply is different for anterior two-third, posterior two-third and posterior most area. That is because of that derivation from the embryological, the pharyngeal arches. This is derived anterior by the first, so it is by the lingual of your the first branchial, the pharyngeal arch is your it is supplied by the lingual nerve, and posterior by the glossopharyngeal, and posterior most is your vagus or by internal laryngeal nerve. But again there is a change for chorda tympani. Nerve is supplies all the remaining papilla except the vallet. The circumvallate, which is very close to the sulcular terminalis, is supplied by glossopharyngeal, and then we have the internal vagus also supplying the taste buds or the papilla. So this is how you can see the lingual which the lingual nerve which supplies the anterior two-third of the tongue. Histology, basically they are made up of skeletal muscle, that is striated skeletal muscle, and they are supported by connective tissue. The dorsum of the tongue has a rough surface and it is non-keratinized squamous cell epithelium, and then the ventral surface is more smoother and it is also your non-keratinized squamous cell epithelium which is present. Now coming to the taste phenomenon, that is at the tip of the tongue there is a sweet taste is felt better at the tip of the tongue, salty at the lateral borders, this green color structure, bitter and sour at the center, and then posterior most and the area we have sour and bitter. Okay, this is how the taste buds are like. Basically these help us to uh, to perceive our food better and enjoy the food what we eat. These are responsible for making us feel the taste of the food. Now coming to the classification, this is very important because based on this our prosthesis, especially your complete denture prosthesis relies on. So we have class 1, class 2, class 3, it was given by right. So class 1 is the most favorable, where we have enough space near the lateral throat area and the floor of the mouth, there is enough space present such that the retention and stability of the denture is better in these cases. The rest two cases is not moderately the space is present, and class 3 has no space at all. The lateral throat area space is completely deprived and the retention and stability is compromised. So we have to see that we can do certain modification in our impression making techniques and to improve the retention and stability. Also in teeth arrangement we can do certain modifications such that the stability of the denture is maintained in such cases. Then we have functions of tongue. Basically, the tongue helps us in taste because there are taste buds. I initially told you that taste perception or the enjoyment we get by chewing our food is by these taste buds which are present on the tongue. So tongue basically helps us in tasting, makes our food taste better. And then we have, it helps us in speech phonetics, which I'll be talking a little later. It helps us in chewing the food, okay, in grinding and chewing the food, because it pushes the food bolus from one side of the arch to the other side. It is first pulled from the anterior surface and then it pushes the food so that the patient can nicely grind the food, and later the tongue itself guides the food into the oropharynx, and later it is gone into the digestive tract. Then we have they produce a certain amount of fluid such that the food is nicely lubricated, such that the chewing capacity is increased because it is well lubricated. And then finally, tongue tells us how well we are, like what is our medical status. Okay, by looking at the tongue, there are so many diseases which are identified, and it is the first line of defense or whatever it is present in our oral cavity. Okay, this is a video which shows how the food is ingested inside, and by it is taken over by the tongue from the anterior surface, and how it is been transferred to the lateral surfaces of that the posterior area, and how the food is been crushed, and how what tongue plays, like you can see how the tongue is lifting itself and pushing the food bolus on either side of the occlusal surface of the posterior teeth, and from there how it is pushed to the oropharynx region. The tongue is guiding the food bolus into the oropharynx region, and finally it has been digested in the gut. So this is how is the chewing and how tongue is helping us in chewing the food. Now we have so here we have our the you can see how the tongue is helping in speech. It is one more function the tongue provides us, that is it is coming in contact with the teeth and the alveolar surface of the upper area, that is maxillary arch, and also the maxillary teeth for pronouncing certain words. Okay, so how the tongue plays a role has been shown here in this video. You can see how the tongue is moving up for different uh, the the speech, how it is carry forward here, how the letter T, D and L and N is pronounced with the help of tongue. So the tongue either touches the dental area, or it touches the alveolar area, or maybe the palate. Okay, so and different sounds are produced. Okay, what are those sounds? A little later I'll be explaining it to you all. Next we have coming to the main thing, that is prosthodontic consideration. So the first thing is role of the tongue in tray selection and adjustments for optimal prosthetic fit. So before going to this, I would like to tell that when we start with our bottom molding, and when we start with our secondary impression, so we have a special tray with us. So the special tray, most of us what we do is we take the special tray, a little bit of adjustment we see, and then we start with the bottom molding procedure. No, that is not right. Okay, we have to do something known as tray extension. We have to check for the tray extensions. Okay, it has to be checked properly, then only we have to proceed with our next step, that is the bottom molding. Let it be using green stick or a putty, but then we have to modify the tray according to the anatomy of that particular patient. Okay, so what we have to do at the tray selection or at the tray extension stage is what I'm speaking here. You can just check this video wherein the tray extension is carry forwarded. So here the patient is asked to lift the tongue up and move on either side, okay, on either side, left lateral and right lateral. When we do that at the area near the posterior and the middle mylohyoid area, okay, the posterior and the middle, that is the retromylohyoid and the middle mylohyoid region, your alveolingual sulcus is divided into anterior, middle and posterior. So at the middle and the posterior, if there is the lifting of the tongue, that means the tray is overextended. You have to ask the patient to protrude the tongue and also move the right lateral and left lateral movement of the tongue. If at all vigorously the tray gets lifted up from that region, that means the tray is overextended. Then we have to trim that overextension and then proceed with a border molding procedure. Similarly, when we do ask the patient to put the tongue out and ask the patient to touch the upper lip or rub the alveolar area of the maxillary region, and there is again vigorous lifting of the tray, it means that the anterior surface of the tray is overextended. So we have to trim the anterior surface. Even at the retromolar area, when the tongue is protruded and there is no space near the lateral throat area, then also the tray gets lifted up, so it means that the space provided at the lateral throat area is not sufficient. Okay, if it is not sufficient, accordingly the tray is modified and then the impression has to be made. Okay, this is what we have to note it down. Also we have to mark those areas and then start trimming those areas and then proceed with our bottom molding. Next is, here is a case wherein the denture, no, a relining method was followed here because there was the complaint of loose denture. The extensions were not good, or the equalization procedure, there was some fault because of which the denture was not very retentive. Because it is not retentive, a relining method or technique, so wherein border molding was repeated again. So here also, the as you can see, the patient is, no, you can see how the tongue moves and how that area is recorded. So for recording at the during the border molding stage, for recording, it's the same techniques which are followed. Okay, for how, what all we followed for the tray extension, the similar techniques are followed here. For the posterior most, that is the alveolingual sulcus, that is the retromylohyoid, mylohyoid and premylohyoid area, the tongue is moved laterally. Okay, it is moved on the left and the right side of the tongue is moved right and left, and also the tongue is protruded and then it is moved right and left. Okay, or else what we can do is we can ask the patient to touch the right cheek and the left cheek. Then also the area, because of the space of the floor of the mouth which is raising up, and then the adequate space is allowed for the impression material, that is how we record that area. When it comes to the anterior area, the patient is asked to protrude the tongue and touch the upper lip or rub the upper lip or touch the alveolar surface of the maxillary arch. Okay, by that the alveolar, and also the if there is a lingual frenum which is present, that is relieved by this particular action of the tongue. Okay, this is how it has to be done. And at the retromolar area, again there also you apply the material and ask the patient to protrude the tongue, and also to you apply pressure against that particular region such that that retromolar area is recorded properly. So here also tongue plays a vital role in making the secondary bottom molding and secondary impression. Okay, so it helps in retention, and also your stability of the denture is maintained. So next, the role of the tongue in occlusal plane and jaw relation in prosthodontics. So here what we do is, like, we have like when we do our maxillomandibular, we record the maxillomandibular relation, we see to it that the lower rim is in line with our the lateral borders of the tongue. Okay, that is the where the lateral border of the tongue should be in line with the your um, uh, lower rim. Okay, lower rim. Not only that, even at the retromolar area, it is divided into anterior 2/3 and posterior 1/3, to where the occlusal plane is adjusted. So in that junction, in that area, the lateral surface of the tongue also should rest. That is an indication that how, and that is how the tongue helps us. Not only in that, knowing the occlusal plane, it also helps us in recording the centric relation. Most of the times, by the methods which are used for recording centric relation fails, then we ask the patient to roll the tongue backward and also swallows the saliva at the same time, such that the mandible or the condyle moves into its centric relation position, and we can record the centric relation in our complete denture patients. This is how we do. So this is how the tongue plays a role in our jaw relation, that is a vertical jaw relation procedures. Okay. So next is your role of tongue in teeth arrangement and denture stability. So here also it is very important such that we arrange the teeth at the center of the ridge for the mandibular denture. The teeth arrangement is done on the center such that there is a balance between the cheek and the tongue muscles which are present, and also the forces are dissipated uniformly if it is on the ridge. Okay, if the space provided at the lateral throat area is very minimal, then also we arrange the teeth on the, or if the ridge is very resorbed, also we arrange it on the crest of the ridge, and also sometimes we follow a lingualized occlusion such that the stability of the denture is maintained in such cases. So lingualized occlusion is commonly followed when there is resorbed ridge and also when there is less lateral throat area space provided. So here you can see for the final denture how the tongue movements again are carried out and checked for the retention of the denture. Okay, if again the denture is lifting up at the posterior, that means the area at the mylohyoid, pre-mylohyoid and the post-mylohyoid, retromylohyoid region is overextended. Similarly with the anteriorly, if there is lifting up, you can appreciate here how nicely she is taking her tongue on either sides and also an anterior, okay, to see the retention of the denture. This is what is done at trial and also at your uh, final insertion. Basically in trial sometimes the retention is compromised because we do block out the undercut areas, so it is most commonly you check for retention during the final insertion of the denture. Role of the tongue in speech considerations for denture. So here again I would like to show this video wherein
D,
D,
N,
N,
S,
S,
L,
L,
K,
K,
N.
N.
Okay, here now you can appreciate how the tongue, not in all the letters she has pronounced, you can appreciate it well because she's kept her teeth too close to each other while talking. Okay, but most of the time, like, but still you could see the tongue which moves, like when you pronounce letters like th or that, this. Okay, so at that time, that those are all one which comes under linguodental sounds. Okay, so you have your sh sound which comes under your lingo-alveolar sounds, wherein the tongue, tip of the tongue touches the alveolar surface of the anterior region of the maxillary area. Okay, so lingual dental, it touches the anterior, I mean the lingual or the incisal surface of the anterior teeth during pronouncing th, that, this, these words which starts with th. Okay, and then we have nasal letters like k, ng, which we, the tongue touches the palate to pronounce all these nasal sounds. Okay, this is how the tongue plays an important role. Now for example, if you have placed the teeth too far and the overjet is increased, then this s sounds like sh, or else there is liberation of air and there is lisping. And also if the thickness of the denture at the anterior surface is too thick, okay, too thick, the even the tongue, there should be a furrowing of the tongue. If the furrowing of the tongue is too deep, okay, if it is too deep, then there is a sound, whistling sound, which is heard. So that also depends on how much the teeth, the tongue is getting furrowed. If it is getting furrowed too much, there will be a whistling sound when you talk. Okay, so whistling and lisping is two different things. And also if there is no space for the tongue, the teeth are arranged too lingually, that will affect the speech. Okay, not only that, if also the palatal surface, the thickness of the tongue, the palatal surface is too thick, it will affect the nasal sounds like n, ng. So these all things we have to keep in mind when we are fabricating a denture. So speech is very important. These are the different functions of a complete denture: speech, mastication, your and then you have aesthetics. Okay, all these are different. So in all these areas, tongue plays a major role. If it is arranged to anteriorly, the tongue no keeps protruding out. If the overjet is too much, the tongue keeps protruding out. And then if it is placed to inside, again there is less space for the tongue. Okay, so all these things should be kept in mind when we are doing our teeth arrangement. So not only that, as you can see here, there is a proper, we say it as a reverse S-shaped curve. That is your alveolar-lingual sulcus, a reverse S-shape. That should be maintained, and how well the design of the denture, because these help, and also the polished surface, because the tongue is very, very sensitive organ. Okay, it can take any kind of roughness which is present, and it will keep sending the stimulus to the brain, and keep the patient will not be adjusting to the denture. He keeps complaining that he is not satisfied. He feels some kind of irritation which is there, and is not unable to tell what is that, why he is not satisfied with the denture. Not only that, even the muscles which are attached here, if you don't follow this architecture, then we'll land up in trouble. So it is very important that the polished surface and the contour and the foot through the formation is on the denture is important. Next, coming on to the neutral zone technique. Neutral zone is nothing but there should be a balance between your tongue and the cheek muscles. So the teeth should be arranged in such a way that there should be balance between, and there is no extra forces and dislodging forces, because this technique is most oftenly followed in resorbed ridges. Okay, in resorbed ridges there is no mechanical retention because the ridges are too flat. Okay, we don't get the retention through the slopes of the ridge. So we go in for this technique. So here again you can see in video how this technique is done. So we use impression compound during our jaw relation time, and then we ask the patient, we make him do certain functions like drinking or swallowing, drinking water, swallowing the saliva, or sucking. Okay, all these functions are made, and then the functional record is recorded, and an index is made on which again the wax is poured, and your conventional way your denture is fabricated later. This is how the neutral zone, and during these functions the tongue and the cheek together balances, and there is a proper functional record which is obtained, and which is later transferred to improve the retention and stability of the denture. This is how it is done. So prosthetic reconstruction of tongue, like most of the cases in cancer, in situations wherein the glossectomy of the tongue is carried forward, so it becomes difficult for the patient to talk or to eat. Then there is prosthesis like tongue prosthesis which are given. Either we can follow a meshwork like this and use silicone over this and give a tongue prosthesis, or else with or acrylic itself, it is attached to your lower denture, and then a tongue which makes the quality of life little better, the speech little better with such prosthesis for these glossectomy patients. Then we have something known as obstructive sleep apnea, which is very commonly seen in hypertensive and obese patients, wherein there is there is a lot of relaxation of the tongue muscles, and because of which the space over here, you can see here the air circulation is good, but here it is obstructed. There is no air circulation, because of which I can show you this in video, wherein uh, there is because of this obstruction, what happens is there is continuous stimulus from the brain, and it wakes up the stimulus, like it wakes up the person from his sleep to tell him that he has to move his tongue forward for a better air circulation. Okay, so each step there is no proper sleep pattern followed, because of which the health deteriorates furthermore. Due to this, it is very important we give a mandibular advancement prosthesis like this, wherein the mandible is pushed forward and there is space created and there is a better breathing, the air circulation is improved. If not that, uh, tap prosthesis is given, you can see in this video. Okay, this is what happens, like normally if the air circulation is normal, but in cases where the tongue falls back and it is shut, there is no air circulations. So in these cases we have to rotate the jaw, or take the jaw more forward, or this airway should be restored, this space should be restored. To that, what we do is, like in this video, basically it is showing how the patient is awakened by the stimulus from the brain to repeat and move the jaw forward and take the tongue a little forward for circulation. But with this particular device, which is known as the flex tap or mandibular advancement device, the mandible is got forward. You can see here how the mandible is taken forward for improving the airway, and the air is, this is how, see, the mandible is getting forward and the improvement in the circulation is seen over here because of the device. Then not only in complete denture patients, the most common problem what we face, as I told you in the beginning, this particular organ is movable and it troubles us a lot every time. Even when we are preparing the tooth, if there is macroglossia, it is very, very difficult to handle and do the tooth preparation without the tongue interfering so much and applying the pressure. Each time with the mirror also, there is a lot of pressure applied, and we are straining our hands also while we are retracting. So we can use stick retractors, or we can use a rubber dam which is very thick, such that this the pressure from the tongue is avoided. If not that, zero pressure mirrors are available now, which can be also used along with the cheek retractor, okay, as such that you can have a proper tooth preparation. Especially at the posterior area, it becomes really difficult because there is a problem with accessibility, and also if the tongue is too big or tongue is very hyperactive, it keeps pushing and it is difficult to prepare. So with this same problem, since I used to face every time, I have come up with a new design of cheek tongue retractor, which I followed. I mean, this particular thought came to me because of this gardening device which they use for pulling out the bushes or grass. Okay, so this is how it pulls out. So with the similar design, I have designed this tongue retractor which has bulbs at the edge such that it doesn't injure the floor of the mouth, and also these tooth-like structures which are present here are, or the claws which are present over here, are very close to each other so the tongue doesn't pop out. And also there is a grip to hold. Okay, mouth mirror, most of the time all of us have felt, we feel very it is very makes the hand very tense, and there is a lot of strain and then pain later on. Okay, that is can be because it is lightweight, it is 3D fabricated, and it's very light, and there is a grip over here through to which we can nicely retract the tongue. I have sent this for patent and it is under process. So to conclude, tongue is an integral part of oral anatomy. It is its nature as such as in prosthodontic has been controversial due to its anatomy and action on lower dentures. It is imperative that the prosthodontist have a proper knowledge of anatomical function, physiological aspects of the tongue so as to rehabilitate the patient to optimal level as possible. As I already told, the ultimate goal should be to improve the quality of uh, the the quality life of the patient. Okay, there should be a good a prosthesis such that the patient's speech, the patient's chewing capacity, and also aesthetics is better. And we are also, we can also follow good techniques, and we can also do a better work if we know the anatomy, physiology, and the overall functions of the tongue. It's very important to know about this particular organ such that we can plan a better prosthodontic treatment. To summarize, we spoke about the embryology, we spoke about the anatomy of the tongue, the root, the apex, the base, and then we spoke about the muscles, intrinsic, extrinsic muscles. Later on, we spoke about the arterial supply, the venous supply, the lymphatic supply. Then also we spoke about the papillas, different papillas which are present. There are four kinds of papillas which are present. We also spoke about uh, the prosthodontic, under prosthodontic consideration, what all things we have to remember while doing tray extension, while doing while making an impression. Also we spoke about the jaw relation, what all things, how the tongue plays a role, how tongue plays a vital role in teeth arrangement, also in denture insertion, in final, what and all we have to think is what and all we have to see. We have spoken about those things. And also we spoke about the sleep apnea and also glossectomy patients, wherein how the prosthesis can be given. We spoke about neutral zone method, how in resolved ridges the tongue plays a vital role and there is the forces which are balanced in neutral zone method. And lastly, we spoke about the tongue retractors while doing FPD tooth preparation, how helpful they are in retracting the tongue. So if there is any questions, you can always contact me. My email ID is provided here, and then you can ask me. And if any questions are there, you can ask me now also regarding this particular topic. These are my references. Thank you. Once again, I would like to thank Karnataka Prosthodontic Society for giving me this opportunity to teach the young minds, and to HKES'S NIJALINGAPPA Dental College for providing me this opportunity. Thank you all. Thank you very much.